Assalamu alaikum everyone and good evening. I'm Mohammad Aljumaa, a fourth year medical student, and inshallah today I'm going to talk about gastric disorders. Inshallah, we're going to cover multiple topics from gastritis to H. pylori, ulcers, upper GI bleeding, gastric neoplasia, and post-gastrectomy syndromes. طيب. To begin with briefly, let's start talking about gastric anatomy. So first of all, we have the cardia, which is here, which is the entrance to the stomach. Then we have the fundus, the uppermost part of the stomach, then the body, then the pylorus, and finally the pyloric sphincter, which is located between the stomach and the duodenum. Then we have the blood supply, which comes mainly from the celiac trunk, okay? And we have three major branches. First, it's the left gastric arteries, which are here, tamam. Then we have the common hepatic artery or hepatic artery proper. And then we have the splenic artery, which is, as you can see it here, behind the stomach, tamam. طيب. What supplies the greater curvature? First of all, we have, as you mentioned, the splenic artery, which is behind the stomach. It gives us the left gastromental artery, tamam. It anastomoses with the right gastromental artery to supply the greater curvature, as you can see here, okay? طيب. Now, for the lymphatic drainage follows the blood supply, so they run in parallel with the arteries. We also need to know that tumors or gastric tumors can metastasize to other organs through the lymphatic channels, and the lymphatic nodes are staged by stations. We have D1 dissection and D2 dissection. D1 dissection is from station 1 till station 6, while D2 dissection is from station 7 to station 12. So no need to know the names of the lymph nodes, بس والله we have two dissections, and the first is from station 1 to 6 and the next is from 7 to 12. طيب. Let's start with acute gastritis. What is acute gastritis? It's an acute inflammation process where we have focal necrosis of the mucosa of the stomach in a normal stomach. There's no any chronic condition in it. تمام? Why does that happen? Due to the breakdown of the gastric mucosal defenses. We usually have protective factors and damaging factors. We have imbalance between them, causing this damage or this acute inflammation. It can be associated with the use of NSAIDs, corticosteroids, alcohol abuse, and cigarette smoking. How do patients present? They usually come with painless bleeding, epigastric pain, nausea, vomiting, and superficial small erosions. And also you need to know that acute gastritis, it's one of the major causes of hematemesis or vomiting blood. طيب. As you mentioned before, we have protective factors and damaging factors. No need to know all of these صراحة. I did put them all and they were in Dr. Fahad Sahibani lecture, because we don't know what he may bring. So just know the H. pylori, NSAID, and smoking, and others is just if they come in the SAQ. طيب. Now, as you can see here in the acute gastritis, in the histological picture, we have a neutrophilic infiltration of the lamina propria and the superficial epithelium, which tells us that this is an active inflammation and it's acute since we have the neutrophils. Here, this is a gross picture of the stomach, tamam, of the gastric wall, where you can see that we have many red spots. Okay, this is we can say that it's a reddish mucosa with the small erosions. Now, for the chronic gastritis, from its name, it's a chronic, so it's more persistent than acute gastritis. However, it's less aggressive. طيب, how does it present histologically? First of all, we have glandular atrophy, intestinal metaplasia, and we don't have erosions in chronic gastritis. Okay, guys, this is very important, and this is what distinguishes the chronic gastritis from the acute gastritis. Now, chronic gastritis can later on, if it wasn't treated, can later on lead to gastric cancers, adenocarcinoma, and malignant lymphoma. Now, what are the causes and types of chronic gastritis? We have two types, or main two types. We have the autoimmune gastritis and the H. pylori gastritis. Now, the autoimmune gastritis mainly happen in the fundus, while the H. pylori happen in the antrum. Okay. Now, as you can see here are the causes. صراحة, the main two causes are the first main cause, it's the H. pylori. Follows it is the pernicious anemia. تمام. Those are the most common, but come on, read the rest because also they were in Dr. Sahibani lecture. Just know them. Memorize the H. pylori and pernicious anemia and NSAIDs. طيب, autoimmune chronic gastritis. Okay, how are they classified? First of all, it's an autoimmune type. It involves, as you mentioned, mainly the fundus and within the body, and it's associated with pernicious anemia. Why? طيب, first of all, we'll discuss how does it happen and why it's associated with the pernicious anemia. First of all, we'll have autoantibodies against the parietal cells and intrinsic factor. This will lead to the destruction of the parietal cells. And as we know that the parietal cells secretes hydrochloric acid, okay, and the intrinsic factor, which are essential for the digestion of the essential for digestion and the absorption of the vitamin B12. Tamam. So this, when we have the destruction of the parietal cell, this can lead to hypergastриnemia, and we will have excessive gastrin, because the parietal cell usually inhibits the G cell from the production of gastrin. So we'll have hypergastrinemia and G cell hyperplasia, and eventually carcinoid tumor. So what complications can we have from the autoimmune chronic gastritis? First of all, we may have vitamin B12 deficiency leading to megaloblastic anemia. Then we can have achlorohydra, as you mentioned, because the parietal cells usually produce the hydrochloric acid, so we won't have hydrochloric acid anymore. So we'll have hypergastrinemia, and we'll have increased the risk of having gastric adenocarcinoma. Time. As you can see here on to the picture on the right, this is an immunofluorescence stain of the gastric mucosa, and these bright green spots, as you can see them, those are autoantibodies against parietal cells. تمام. So this tells us that no, والله, this is an autoimmune gastritis. طب how do we test for that? First of all, we'll check the IgG levels. We'll have high IgG levels. We'll check for the B12 and homocysteine and the methylmalonic acid. The B12 will be low, while the homocysteine and the methylmalonic acid will be high, because B12 is used in the metabolic process of the homocysteine and the methylmalonic acid. And in the serology, we'll have antibodies that are against parietal cells. And usually they're associated with slight female predominance and other autoimmune diseases like, for example, Graves, Hashimoto's, and diabetes. Now, we're going to talk about the H. pylori chronic gastritis type. Acute H. pylori usually it's asymptomatic, or it's mild, or doesn't cause any symptoms. However, the symptoms come when we have chronic infection of H. pylori. Now, chronic antral H. pylori infection will lead to increased gastric acid secretions and eventually peptic ulcer disease and multiple complications that we'll talk on later. تمام؟ طيب. First of all, as you can see here, this is a silver stain for the gastric mucosa. H. pylori is sitting on the surface, as you can see here, okay, and not inside the cell. Then we have the antral glands that are producing mucus. And we have, since it's a chronic gastritis, so we have lymphocytes and plasma cells that are sitting here. Those are the brown spots. Okay, those are lymphocytes and plasma cells. Now, here, this is a specimen for the gastric mucosa. As you can see here, this red color tells us that this is chronic inflammation of the gastric mucosa. And we have thick folds. Okay, those are thick folds representing the rugal folds, and they are becoming thick due to the inflammation. Now, if we didn't treat the chronic gastritis, we'll have loss of the gastric glands, we'll have thinning of the mucosa, and the rugal folds may become flattened, or we even lose them. Now, also these histological pictures, we can see those are for the H. pylori chronic gastritis. Here in the normal stomach, the mucosa usually it's thick, and we have gastric glands. However, as you can see here in the atrophic gastritis, we're having aggregates of chronic inflammatory infiltrates, and the mucosa is thin. Type. Now, okay, so we've talked, this is H. pylori chronic gastritis. We've talked about A, which is the silver stain. Now let's go to B. This is a densely inflammatory infiltrate, mainly, as you mentioned, lymphocytes and plasma cells, and they are located in the lamina propria. Now for C, this is glandular atrophy, and also we can see that we've lost some gastric glands. Now, finally, D is an intestinal metaplasia. It's a premalignant. This is a premalignant change. Why? How can we know that this is intestinal metaplasia? Due to the goblet cells that are found here. Okay, as you can see them, those pale bluish cells. Okay, this, if it wasn't treated, it can turn on into adenocarcinoma later on. And this is a summary for both types, if you'd like to check it. تمام. Now let's talk about Helicobacter or H. pylori, Helicobacter pylori or H. pylori. So what is H. pylori? H. pylori, it's a gram-negative curved rod bacterium that produces urease, protease, and cytotoxins. The main one that cause a huge effect is the urease. It converts the urea to ammonia, creating an alkaline environment, okay, and helping itself to stay in the stomach, okay. And as I mentioned, it neutralizes the gastric acid. Now, and previously, as I showed you, the silver stain, it colonizes the mucus layer and it doesn't penetrate the gastric tissue itself. Okay, and it adheres to gastric epithelial cells by specific receptors like the blood group O antigens. It's mainly transmitted by fecal oral route and can be transmitted by person to person or waterborne. Now, how does H. pylori causes its complications that we'll be talking about later on? It has four main violence factors. The first, it's flagella, which enables the motility through gastric mucus. Then we have urease, which converts the urea to ammonia, raising the local pH, alkalizing the gastric environment. Then we have adhesions, which mediate the attachment to gastric epithelial cells. Finally, we have the toxins, which are, for example, CAG-A and VAC-A genes that trigger in the inflammation and the immune response. Now, these mechanisms shift the balance between the mucosal protection and injury, total injury, causing multiple complications like gastric carcinoma, peptic ulcer diseases, and gastritis. Now, persistent infection of the H. pylori, first of all, causes chronic antral gastritis. Then it may become pangastritis, affecting all the stomach. And later on, it may result become multifocal atrophic gastritis and intestinal metaplasia, which later on it can be turned into gastric adenocarcinoma and mild lymphoma. Now, other contributing factors with the four violence factors that we've mentioned, the first is hyperacidity, which aggravates injury. So how does this contribute? So H. pylori, it damages the somatostatins or the D cells, causing an increase in the gastrin release, increase in acidic secretions from the parietal cells, and this excess acid will damage the already inflamed mucosa. Second of all, we have the pro-inflammatory cytokines that attract more phagocytic cells. For example, the CAG-A, it induces the cytokine release, and this will cause, as I mentioned, attraction of the inflammatory cells. Finally, we have thrombotic occlusions of the surface capillaries that leads to necrosis. So the H. pylori will cause an inflammatory damage to the microvascular structure, leading to microvascular thrombosis. This will decrease the blood flow and lead to ischemic necrosis and worsening the injury that H. pylori will cause. Now, when do we test for H. pylori? So we have standard indications and controversial indications. The standard, it means that where we need to test for H. pylori and we need to treat it, okay? However, the controversial indications are cases where testing are reasonable, however, they are not mandatory, and you can not test for it. And it's okay if you didn't test for it. Like, for the standard indications, we have active or previous peptic ulcer disease, gastric mild lymphoma, because gastric mild lymphoma can arise from H. pylori, post-resection of early gastric cancer, okay? So we do check for H. pylori so we can make sure that the rest of the stomach is protected, and uninvestigated dyspepsia in high prevalence areas. Now, the controversial indications may be unexplained iron deficiency anemia, because the H. pylori, as you mentioned, that it causes chronic inflammation, and this can lead to decrease of the absorption of iron. ITP or immunothrombocytopenic purpura, the H. pylori can cause immunodestruction for the platelets, so we can check for it. Then we can other indication is first degree relative with the gastric cancer, immigrant from high risk regions, and chronic PPI or NSAIDs use. طيب. H. pylori diagnostic tests. We have multiple tests, okay? The gold standard and the best for diagnosis is the urea breath. The best for diagnosis is the urea breath test. It tells us if there's an active infection right now. So how do we do usually the urea breath test? What we do is that we give the patient a urea to drink, and we'll be labeling the carbon in it, either C3 or C14. If H. pylori is present, the bacterial urease will break the with the urea to ammonia and CO2. Now, this CO2 will be absorbed in blood and will be exhaled and while breathing. And then we'll take a breath sample and we'll check if there was the labeled CO2 was there. Then we make sure that yes, this patient have the infection. Then we have stool antigen test, rapid urease test, which we require a gastric biopsy. So for the biopsy, we do histology, culture, and rapid urease test. We also do serology. However, serology doesn't. It may tell us that there's a diagnosis, there's an infection, but we can't use it later on. Like for example, if a patient took medication, we can't use it for to check if he still has the infection or not. And finally, PCR, which is emerging right now. Yani they didn't use it much before, but right now they're using it frequently. Okay, what test should we choose? Now, if we're having alarming features indicating endoscopy, for example, family history of upper GI cancer, age above 55, and with a new onset of dyspepsia, iron deficiency or GI bleeding, we use rapid urease test, and of course we do with it culture since we're taking the biopsy anyways. Yani. If there are no any alarming features, we do use urea breath test. Now, as you mentioned, H. pylori has multiple effects. So, H. pylori contributes to the following: gastritis, peptic ulcer disease, gastric ulcers, duodenal ulcers, and gastric cancers and lymphoma. Now, for the non-GIT diseases, it may contribute to IDA, autoimmune thrombocytopenic purpura, and coronary artery diseases. Now, how do we treat H. pylori? Mainly, we treat it by triple therapy or quadruple therapy. تمام. The quadruple therapy right now it's the first line. تمام. Triple therapy we use PPI, amoxicillin, and clarithromycin. With the quadruple therapy we use PPI, bismuth, and tetracycline and metronidazole. Pylora, it's a quadruple. However, it's three drugs in one capsule, and PPI is being taken separately. Now, if the triple and the quadruple treatments failed, we go to levofloxacin based therapy or rifabutin based therapy. تمام. And most of them and all of them we use it. The duration is 10 to 14 days. Now, how can we say that a patient is خلاص he's cured from the infection? The patient should have a negative urea breath test or stool antigen test for after 4 or more weeks of taking the antibiotics, and with the PPI stopped for at least 2 weeks. Now, why do we use H. pylori is a خلاص we can treat it with antibiotic? Why do we use PPI? PPI helps eradicate the H. pylori by raising the gastric pH and helping the antibiotic stability and efficacy. طيب. Let's talk a bit about the PPI. PPI absorption decreases with food, so you need to take it 30 minutes before meals, except dexlansoprazole, which can be taken independent of meals. All PPIs are metabolized by the hepatic CYP enzyme, except denatoprazole. Indications for PPI are Jordan-Barrett's esophagus, peptic ulcer disease, H. pylori, and acid hypersecretory states. Now, what are some side effects for PPI? First of all, hypochlorhydria, which can later on lead to hypergastremia and G-cell hyperplasia. Infections like C. difficile can cause also pneumonia. We have hypomagnesemia, slight increase in the fracture risk, and reduced absorption of iron, calcium, and vitamin B12. Now, what is peptic ulcer disease? Peptic ulcer disease is a break in the GI mucosa with a 5 or more than 5 of millimeter that penetrates beyond the muscularis mucosa. It's smaller superficial mucosal breaks are called erosions and not ulcers. What are the common sites in descending order? Sorry. First of all, you have duodenum. The first part is the most common. Then we have stomach. Then we have gastroesophageal junction, margins of gastroduodenostomy, multiple sites in patients with Zollinger-Ellison syndrome. We're going to talk about it in a bit, inshallah, and ectopic gastric mucosa, for example, Meckel's diverticulum. طيب, as you can see here, guys, this area we've talked about before, the Silverstein mucus layer. Then we have B. This is a duodenal ulcer in the first part of the duodenum. This is a chronic gastric ulcer, and here, as you can see, below the diaphragm, okay, we have some air under the diaphragm. This is an evidence that we have a perforating gastric ulcer. طيب. Now, peptic ulcer disease. Ulcers develops when the damaging factors outweigh the protective mechanisms. Okay, and H. pylori, it's the most common cause, followed by the NSAIDs. We have two types of ulcers. We have duodenal ulcers and gastric ulcers. Most gastric ulcers are benign, while sorry, most gastric ulcers are benign. However, they may become malignant. However, the duodenal ulcers don't come malignant, so we don't need biopsy for them. While the gastric ulcers, we do need biopsy, and duodenal ulcers are the most common ulcers. Grossly, they appear clear, sharply demarcated, and elevated around the edges. Now, the peptic ulcer disease, we have the protective factors and damaging process. صراحة damaging process يعني just know some of them بس يعني please read them all لأنه it's from Dr. Sahiban lecture and كمان once يعني you don't know what he may bring ف just know them please يعني تمام. طيب, what can peptic ulcer disease causes? It may cause intractable pain that cannot be relieved by any medications, bleeding, which 25% of ulcer-related death, perforation, peritonitis, and penetration, which is 2 out of 3 of ulcer-related deaths, and finally the gastric outlet obstructions, causing abdominal pain and vomiting. Now, the gastric ulcers, they are mainly in the on the lesser curvature, and up to 50% have a concurrent duodenal ulcers. How do they look on gross? They are less than 4 centimeter in diameter. They are round to oval shape, and also we have rugal folds that radiate toward the ulcer in a spoke wheel pattern. And this is an example of gastric wheel, and it has most of the features that we've talked about. It's small, less than 4 centimeter. We have some rugal folds. We have some heaped up margins. Okay, and it's sharply demarcated. طيب. Acute peptic ulcers or stress ulcers. Those ulcers are not like peptic ulcer disease caused, for example, by H. pylori or whatever. Yani. Those are related to physiological stress, and they occur mainly in critically ill patients and those that are taking specifically NSAIDs. So how do they look like? There are multiple small ulcers in stomach, scattered in stomach and duodenum. They're usually less than 1 centimeter in diameter. 1 centimeter in diameter. We have no any scarring of the mucosa and submucosa. طب why can NSAIDs cause acute peptic ulcers? Because NSAIDs mainly it causes a mucosal irritation. It inhibits COX, and which mean that it will inhibit decreases prostaglandin, decreasing the bicarbonate and the mucosal secretion, and those are the protective factors for the gastric mucosa. يعني. طيب. As you can see here, we have multiple small ulcers scattered in the stomach, and we have two types of acute peptic ulcers. The first is curling ulcer, while the second is called Cushing ulcer. But when do we have curling ulcer? Curling ulcer is when we have severe burns or major trauma, while the Cushing ulcers when we have intracranial injury causing direct vagal nucleus stimulation, causing gastric acid hypersecretion. Now, NSAIDs are a major cause of, as you mentioned, acute peptic ulcers and chronic peptic ulcer disease, mainly by inhibiting the prostaglandin-mediated gastric protection, which are the bicarbonate secretion and the mucosal blood flow. Now, how does the NSAIDs function? It blocks COX-1 and COX-2, decreasing GI protection and increasing the ulcer risk. For some example of NSAIDs, we have aspirin, ibuprofen, and the best to use, for example, if you need to use NSAIDs and you have a gastric problems, is COX-2 selective, which is, for example, celecoxib. It spares the COX-1, so less GI toxicity, so you can take it and with the PPI. Now, NSAIDs, he focused on the lowest risk. The doctor focused on the lowest risk and the highest risk, so please memorize them. تمام. Some risk factors for NSAID-induced ulcers: age above 60, previous peptic ulcer disease, high dose or multiple NSAIDs, and of course, H. pylori infection. How do we approach these patients? First of all, we do stop NSAIDs if possible. If not, then we take the COX-2 inhibitor with the PPI. And of course, always test and try treating the H. pylori if it's there. Now, as you mentioned before, Zollinger-Ellison syndrome, which is a tumor of gastrinoma, where we have excessive gastrin. We have here massive acid hypersecretion and ulcers, and we do have here ulcers due to the overwhelming acid. Now, what are some key features? There are multiple recurrent ulcers, and they may occur in unusual locations like distal duodenum and jejunum, and they may involve esophagus, stomach, and D1, D3, which are the connections of duodenum. Location of gastrinoma, mainly it happens in the gastrinoma triangle, where we have the cystic duct, pancreatic duct, and D2, D3 junctions. How do we manage the Zollinger-Ellison syndrome? First of all, we give very high dose of PPI. We do localize the tumor by CT, MRI, and then later on we do surgical resection if possible. Now we're going to talk about upper GI bleeding. Now, upper GI bleeding, it's like we do tell that this is an upper GI bleeding not because of the symptoms it causes, but because of the place that the bleeding is coming from. So bleeding originating proximal to the ligament of Treys, we call it upper GI bleeding. It's a junction between the duodenum and the jejunum. The sources included esophagus, stomach, duodenum, liver, pancreas, and biliary system. And mortality is related to the degree of bleeding and the coexisting medical conditions. Here are some causes of upper GI bleeding, and the most common cause is peptic ulcer disease. Now, bleeding peptic ulcers, prognosis is determined by bleeding classification. So what do we mean by bleeding classification? B goes for ongoing bleeding, L for low systolic blood pressure, E for elevated PT, A for altered mental status, and D for any comorbidities or diseases. طيب. Also, we may have important risk factors are the presence of having the bleed classification. We'll have a high risk of hospital complications, high risk of recurrent bleeding, need for surgical intervention, and mortality. Also, we have some risk factors, age and blood transfusion. طيب. What are some factors that are associated with poor outcome of bleeding ulcers? Number one, severe magnitude of the hemorrhage. We're losing much blood, persistent or recurrent hemorrhage, advanced age, we've mentioned before, and medical comorbidities. Now, what are some comorbidities that are affecting the mortality? We have acute renal failure, respiratory failure, chronic liver disease or cirrhosis, and congestive heart failure. طيب. Forced classification, it's a classification based on the appearance of the ulcer on endoscopy. So we have F1, F1A, F1B, we have F2A, F2B, F2C, and F3, okay? So F1A, as you can see here, it's ulcer with active arterial bleeding. F1B, as you can see here, we have ulcer with active oozing. F2A, it's ulcer with a visible vessel, okay? However, it's not bleeding, yani. Here we have ulcer with adherent clot in F2B. F2C, we're having, as you can see, ulcer with a pigmented spot. And finally, here we have clear ulcer base. So no bleeding or any abnormality, except the ulcer. تمام؟ طيب. Now we're going to talk about Dieu-Lafoi lesion. This is a vascular malformation where we have a submucosal artery anomaly that protrudes through the mucosa. And here we're having hurled bleeding. What do we mean by that? It's a small warning bleeding that comes before a massive bleeding. And whenever we have hurled bleeding, we need to treat as soon as we can to prevent the massive bleeding later on. Okay. And as you can see here in this endoscopy, we are having here arterial bleeding. طيب. Now, for the Dieu-Lafoi lesion, the symptoms are painless hematemesis with the melena. Age, it's middle-aged patients. Genders, it occurs more in the males than the females. Bleeding pattern, it's sudden. And the course, recurrent hemorrhage can occur. Now, what do you find in stomach? The mucosa will look normal. We don't have any chronic ulcer. We have only single exposed artery that suddenly bleeds and stops suddenly, yani. Yeah, that's it. Okay. Now we have another thing which is called aortoduodenal fistula. This is an inflammatory fistula that forms between the aorta and the duodenum. It's most commonly due to erosions from a synthetic graft. Okay. So as you mentioned, it's a fistula tract that forms between the aorta and duodenum. It may happen due to aortic aneurysm or infectious aoritis. However, it's most common due to, as I mentioned, erosion from a synthetic aortic graft. Right. And the classic pattern, how does it present? First of all, hurled bleeding as you mentioned, it's a small self-limited bleeding. Then, if it's not treated, it will be followed by a massive hemorrhage. So how do we treat it? The management is surgical. We start with emergency laparotomy. We do control the proximal aorta, and we remove infected or eroded graft. So how do we investigate for the aortoduodenal fistula? First of all, we start with the upper GI endoscopy. Okay, this may miss it, so we make sure with the CT scan with contrast or CT angiography, or we can do emergency angiography. Now, another concept, which is the upper GI angiodysplasia. This causes massive upper GI bleeding, and this is arteriovenous malformation where we have fragile, thin dilated mucosal vessels. They happen usually in the colon and the stomach or duodenum. How do they appear pathologically? It's a flat raised red lesion. It's associated with aortic stenosis and chronic renal failure. How do the patient present? A chronic upper GI bleeding, occult blood loss. So the patient is having blood loss, but from where he doesn't know. We may have IDA and intermittent melanoma. Now, management of upper GI bleeding. So we have four main goals to treat the upper GI bleeding. The first is initial patient assessment. Then we have resuscitation, then identifying the source of the bleed, and finally, institution of specific therapy. First of all, we have the initial patient assessment. We do history, physical examination, and laboratory investigations. History, like, for example, characteristic of the bleeding, any associated symptoms. Physical examination, we check the vital signs or signs of hypovolemia. And for the laboratory investigations, for example, we look for hemoglobin and hematocrit to make sure that the patient is hemodynamically stable. We look for coagulation profile, renal function to check if the patient is having any dehydration. Our second goal is resuscitation, which mainly to make sure that the patient is stable. How do we do that? We do establish 2 IV lines and we give fluids, Foley catheter for urine output, transfusion with fresh frozen plasma or platelets, and finally nasogastric tube if there's recurrent nausea or vomiting. Then we need to identify the source of bleeding. How do we do that? We do that through endoscopy, okay? And we need to make sure that we need to know that during endoscopy, the doctor may, if he sees that he needs to do that, he may provide a therapeutic intervention with the endoscopy. Now, we also do lavage of the stomach using a large orthogastric tube to enhance visualization. So what does that mean? We mean that we're going to remove the blood and clots from the stomach, so that once the endoscopy is there, we can have a better visualization. And of course, we need to protect the airway and nasogastric, and a nasogastric tube can be helpful in this case. Now, for the specific therapy, management of bleeding peptic ulcer disease, it's like there's a process for it. So first of all, we start with medication. We stabilize the patient with medicine. Then we go to endoscopic control. And finally, if that fails, we go to surgery. So first of all, we manage medically with IV PPI bolus, okay? And we also stop the NSAIDs. For the endoscopy, we do have thermal, injection, and mechanical therapies. The first two are thermal, the bipolar electrocoagulation, and the laser coagulation. The third one, it's an injection therapy, epinephrine, fibrin glue, and absolute alcohol. And the last one, it's a mechanical therapy, which is endoscopic clipping. Now, we have, for the surgical, we have duodenal ulcers and gastric ulcers. For the duodenal ulcers, we do suture ligation of gastroduodenal artery and triangle vagotomy. In the duodenal ulcer, it bleeds massively because of its proximity to the gastroduodenal artery. So we need to make sure that we're ligating it. For the gastric ulcer, as you mentioned before, that gastric ulcer has risk of becoming like malignant. Okay, so here we do consider malignancy, and if we can, we do surgical resection. Now we're going to move into a big topic, which is the gastric neoplasia. We're going to go step by step from the benign lesions, pre-malignant, malignant, and finally the non-epithelial tumors. To begin with, we have the mucosal epithelial tumors and the mesenchymal tumors. The mucosal epithelial tumors, we have adenocarcinoma, adenoma or dysplasia, neuroendocrine tumor, and lymphoma. For the mesenchymal, we have GIST or gastrointestinal stromal tumor, leiomyoma, lipoma, and schwannoma. Now, for the benign gastric lesions, we have gastric polyps. We have two types. We have hyperplastic inflammatory polyp and adenomatous polyp. For the submucosal masses, we have lipoma and leiomyoma. So lipoma, it's benign, asymptomatic, and we may have Cushion sign, as you can see here. This is the Cushion sign. While the leiomyoma, it's a pre-malignant, it ulcerates and bleed, and we need a biopsy to check for it. And finally, the last benign gastric lesion is gastrointestinal stromal tumor. طيب, let's start with gastric polyp. What are gastric polyps? Gastric polyps are masses or nodules that project above the mucosa surrounding it. And the causes include hyperplasia, inflammation, or even neoplasia. And we have three main gastric polyp types. We have hyperplastic or inflammatory polyp. We have fundic gland polyp. And the last one, gastric adenoma. طيب. For the hyperplastic or inflammatory polyp, this immediately connects it to H. pylori. As we mentioned, as you can see, the chronic gastritis is in the background of the hyperplastic polyp, which tells us that this is related to H. pylori infection. And if these polyps were actually, and for example, they had inflammatory polyp, and we did check for H. pylori, and we treated H. pylori, those polyp may regress after the eradication. تمام? And it's mainly in the antrum, and macroscopically it presents with a multiple small, and typically they are less than 1 centimeter. Okay, and as we can see here, the histological picture of the hyperplastic polyp, we have enlarged dilated epithelium, reflecting that we're having a regenerative response to the chronic mucosal injury. Now we have the fundic gland polyp, which arises from the fundus and the body of the stomach. It can be either sporadic or seen in FAP or familial adenomatous polyposis, which is a high risk of dysplasia. So the sporadic, it has a minimal neoplastic risk, while the FAP have a high risk of dysplasia. And incidence has increased markedly with long-term PPI use. Why? Because PPI will decrease the gastric acid, decrease the acid, which will cause an increase in the gastrin secretion and G cell hyperplasia, and the gastrin will cause a glandular hyperplasia leading to the funding polyp. Usually they are asymptomatic and they are found incidentally on endoscopy. On histology, as you can see here, we have the dilated funding glands. We do have the microcystic changes that are lined by the normal funding mucosa. Now, a gastric adenoma. First of all, let's talk about this picture. Okay, gastric adenoma, as you can see here, it's showing a proliferation of that plastic glandular epithelium. Tamam, and this makes it a premalignant lesion. In this picture here, we have the lower half, it's an adenomatous epithelium, while the upper half is an intramucosal carcinoma. So why do we call this an intramucosal carcinoma and this adenomatous epithelium? Because here we have an increased anaplasia. What we mean by anaplasia, it's the loss of the cellular differentiation, and the cell doesn't longer look like as it should be. Tamam. Also, we have increased mitotic activity, which means that we're having increased cellular proliferation. Also, the architectural distortion is different. Okay, so those three main things tells us that this area is not like this area. تمام. طيب. Now let's talk about gastric carcinomas. Gastric carcinomas, we have main two types, diffuse gastric carcinoma and intestinal type gastric carcinoma. The diffuse, we have CDH1 mutation or E-cadherin. The E-cadherin, it's a protein that keeps the cells together. So when the junction between these cells is weakened, the cells will become free to move, increasing the risk of having cancer. Also, we have DNA methylation. In others, we have DNA methylations. And we have the second type, which is the intestinal type gastric carcinoma. It's usually, it can happen in patients with FAP and with those who have mutation in the beta-catenin genes. تمام. So those patients will have hyperproliferation of their tissue. Also, they may have microsatellite instability, which means that they are having a defect in the DNA repair system, which will lead to accumulation of the mutations due to the impaired DNA repair type. Also, we'll have a hypermethylation of genes including BAX and IGFR receptor 2 type. In this type of cancer, we have IGFR2. It's being proliferated. So we're having deactivation of the apoptotic gene, which is the BAX, and activation of the IGFR receptor 2, leading to like the outcome will be hyper proliferation. تمام. We also have patients with P53 mutations may have gastric carcinomas in both types. H. pylori infection, the chronic inflammation from H. pylori, as you mentioned previously in the beginning of the lecture, can lead to a gastric carcinoma. And finally, EBV tumors, because they do express some markers like PD1, PDL1, and PDL2. طيب. What are some risk factors and clinical features for gastric carcinoma? So risk factors, we have low socioeconomic status, of course, H. pylori, intestinal metaplasia, mainly chronic atrophic gastritis and pernicious anemia, and specific diet. Now, for the clinical features of gastric carcinoma, the constitutional symptoms, weight loss, nausea and vomiting, we have pain, occult bleeding that may happen with IDA and fatigue, or massive upper GI bleeding. And most of the patients have a palpable tumor. Type. Why do we have weight loss? Weight loss, it's due to the cytokines like TNF alpha, okay, which affects the appetite center. So with those patients will have early satiety, okay, causing due to the mass in the stomach. تمام. Occult bleeding, as I mentioned before, occult bleeding is a hidden bleeding, so it's not visible to the patients, and it's common. You need to know, guys, please memorize. Occult bleeding happens in gastric cancer and right-sided colon cancer. Gastric cancer and right-sided colon cancer. تمام. And the diffuse gastric carcinoma is worse than the intestinal. Why? Because the intestinal usually causes a gastric outlet obstruction and causing nausea, vomiting, and other symptoms, which makes the patient know, yalla, I need to check what's happening with me. Okay, while the diffuse doesn't cause any of these early, so the patient won't know that he's having a gastric cancer. Type. And now for the location of the gastric cancer, we mainly they are in the pylorus and in the antrum, then cardia, body and fundus, lesser curvature, and finally the greater curvature. Now, how do they look like on gross? It's either excavated, ulcerative, or exophytic, like it's protruding like a nodule, for example, or it may be flat or depressed. We call it linitis plastica. تمام. طيب. Lawrence classification. This is a classification to differentiate between the intestinal variant and the diffuse variant. In the intestinal variant, it's mainly in an older male, while the diffuse, it's mainly in younger females. In intestinal variant, we can see that we're having some villi, okay, which telling us that or tells that this is in the small intestine. Okay, so we're having here metaplasia. Also, we're having here, I'm talking about this picture, guys, by the way. And also we're having some goblet cells, okay, which are remnant of the goblet cell metaplasia, which was a precursor of this tumor. تمام. This is for the intestinal variant here. Now for the diffuse variant, as you mentioned, it's in the younger females, and we also have a feature. If you've seen this feature, this is for diffuse gastric carcinoma. It's the signet ring cell. Okay, in the signet ring cell, we have a mucin that's being produced, and it's pushing the nucleus, as you can see here. تمام. It's pushing the nucleus to the side of the cell. طيب. Now for staging and metastasis, we have early gastric carcinoma and advanced gastric carcinoma. The early gastric, it's only confined to the mucosa and submucosa. However, the advanced, it's below the submucosa and it goes into the muscular wall. طيب. The gastric carcinoma can spread to multiple areas, okay, and can penetrate also the wall and the serosa, and this is how it metastasizes. So it goes frequently to the left supraclavicular node. We call it virtuous node. It can also metastasize to the ovary. We call it here Krukenberg tumor. It can metastasize to skin around the umbilicus. We call it Sturm-Joseph nodule, as you can see here. Tamam. And here the virtuous node. Okay. And it can metastasize also to rectouterine pouch. We can call it here plumber's shelf. Tamam. Okay. Now, gastric carcinoma, the intestinal gastric adenocarcinoma, it's usually large in size, more than 6 centimeters. It has irregular borders, necrotic areas, and hemorrhage, and it usually doesn't heal. Okay, this is for A. This is an intestinal gastric adenocarcinoma. Now, for B, this is a linitis plastica. Okay, and it's a diffuse type of gastric cancer where the tumors infiltrate the lamina propria, causing thickening, as you can see here, thickening of the stomach wall. Finally, as you can see here, guys, we're having a signet ring cell. Yani, obviously, this is a diffuse gastric carcinoma. طيب. Gastric lymphoma. We have two main types. The first type is marginal zone B-cell lymphoma or malt lymphoma. And the second type, the most common type is malt lymphoma. The second type is the diffuse large B-cell lymphoma. Now, for the malt, it's a very low-grade tumor. It's associated with a chronic H. pylori infection. So it can be treated if we do remove the H. pylori. Tamam. Now, for the diffuse large B-cell lymphoma, as you mentioned, it's the second most common cause. Second most common. However, it's the most aggressive. It's more aggressive than the malt lymphoma. Also, we have the ABV related, particularly in immunocompromised patients like those who are having HIV or AIDS. Tamam. And the gastric lymphoma makes up around 5% of the gastric malignancies. Now, let's go to the gastric carcinoid. What is carcinoid? Carcinoid, it's a neuroendocrine tumor that arises from the neuroendocrine elements, and because it's gastric, obviously, it's from the gastric wall. Type, what's the difference between carcinoid and the gastric carcinoma? Carcinoids, they grow slower than the usual cancer, tamam? And they are associated with endocrine cell hyperplasia, autoimmune chronic gastritis, and Zollinger-Ellison syndrome. We've mentioned this syndrome before. And they are either classified as low or intermediate grade tumor, depending on their mitotic activity and count. How do they present the patients? They usually present in the sixth decade. Okay, the symptoms depend on the hormone they're producing. But the good thing is in our body is the first pass effect. So usually the GI carcinoids, they secrete hormones, and all of the hormones do go through the liver. Okay, so they get metabolized by the liver and they won't have much effect. However, there's an exception, of course, if the liver is not functioning well. Now, let's talk about the mesenchymal neoplasm. So, continuing with the gastric carcinoid, we have two types mainly, okay, or two pathways. You have the autoimmune gastritis and the gastrinoma, or the gastric carcinoid type. The gastric carcinoid type, it occurs as a single tumor or multiple small tumors, and it's about half to two-thirds of the single gastrinomas are malignant. They also most commonly spread to liver and lymph nodes, and 25% of those patients that have gastric carcinoid also have other multiple tumors as a part of MEN1 or multiple endocrine neoplasia, mainly in the pituitary gland and parathyroid gland. Now, for the autoimmune gastritis, it's mainly in the fundus. It results in severe eclarohydra and reactive hypergastrinemia with a G cell hyperplasia, of course. And this can predispose to development of carcinoid tumor in the antrum. As you can see here, the histological pictures of the gastric carcinoid, we have A and B. We have submucosal nodule that's composed of tumor cells, while here on higher magnification, we have bland cytology that tells us that this is a carcinoid tumor. Bland cytology, we mean it, no, it's not aggressive. Tamam? And please note that they have a chromatin texture. As you can see here, we have chromatin texture, and we call it salt and pepper pattern. Okay, salt and pepper pattern. Gastric carcinoid, it's salt and pepper pattern. Type. Now let's go to the mesenchymal neoplasm. GIST or gastrointestinal stromal tumors. Usually, it's an incidental bleeding. It's mainly it occurs in the gastric wall and not the mucosal layer. Okay, what's the pathology behind it? We have bland sheets of spindle cells, tamam, and they're usually mistaken with leiomyoma, and they have an immunohistochemical marker, which is they are c-KIT positive. What's the origin of the cell? Interstitial cell of Cajal, which is located in the muscularis propria. And this cell serves as a pacemaker cell for the gut peristalsis. تمام؟ طيب. As you can see here, grossly, these two pictures, we can see here that the classical feature for gastrointestinal stromal tumor is embolization and ulceration, okay, here and here. تمام. On histology, as you can see, we have like it's spindle shaped here and here, okay. We're having some spindle shapes, so this tells us that this is a gastrointestinal stromal tumor. Also here, this green circle tells us that this tumor, it's not arising from the mucosa, it's arising from the gastric wall, tamam? And it originates within the wall, as you can see here, okay? And we have spindle cells, we've mentioned that. طيب. Now, what's the molecular pathogenesis? As you mentioned, most of the patients have a c-KIT positive gene, tamam? And c-KIT is a tyrosine kinase. However, those who have c-KIT negative may have a PDGFR-A mutation, which is platelet-derived growth factor receptor A mutation. So it's either one of those, either KIT, c-KIT, or PDGFR-A. Now, proto-oncogenes usually regulate the cell growth, okay? When proto-oncogenes goes into hyperstimulation, they become oncogenic, and activating the KIT mutation will turn the proto-oncogenes into oncogenic genes, driving abnormal proliferation. Now, gastrointestinal stromal tumor, how do we treat them? Mainly with imatinib, if the tumor is unresectable. Tamam. What's the function of the imatinib? It mainly inhibits the tyrosine kinase activity, and it's also effective in chronic myeloid leukemia because in chronic myeloid leukemia you have a BCR-ABL kinase suppression. We do suppress it with the imatinib because BCR-ABL kinase it's a tyrosine kinase function. تمام. Now, macroscopically, how do the gastric adenocarcinoma look? We have two main classifications. I don't think you need to memorize this صراحة. It was in the clinical lecture of Dr. Barakat, but just take a note, have an idea about it. We have Borman and Japanese. We have type 1, 2, 3, and 4 and 5. And in the Japanese, we have 0, 1 to 3. So type 1 to 3, we start from protruding. So type 1 is protruding. And type 2 and 3, they are ulcerative. And type 4, it's diffusely infiltrative. How do we diagnose gastric carcinoma? First of all, we do the gold standard is upper GI endoscopy, and we take multiple biopsies, and we assess for H. pylori. What baseline labs that we need to take? We need CBC, liver function test, and renal functions. And we don't need to forget the rule of thumb, which tell us that if we have a negative biopsy and the patient is a high risk patient, then we do suspect and wallahi, he may have a gastric cancer. We either do repeat the biopsy or do again the endoscopy. تمام. طيب, gastric cancer is confirmed on biopsy. طيب, then later on we need to stage it to know how we should go further with the treatment and if it's curable or not. تمام? So we have a system called TNM system. T for the depth of tumor invasion, N for the lymph nodes, and M for the distant metastasis. تمام? طيب. Endoscopic ultrasound, it's the gold standard for T, or the depth of the tumor invasion, shows the gastric wall layers and the nearby lymph nodes. CT, we use it for any nodal involvement or distant metastasis. And if we were planning for surgery, we do laparoscopy if we detect any occult peritoneal metastasis or any metastasis that is not shown anywhere. And finally, we do PET-CT. However, it's not that efficient for diffuse and diffuse signature gastric cancers. طيب. For the T, we have T1, TIS, okay, T1A, T1B, T2, T3, T4A, and T4B. Please memorize يعني the stagings لأنه it may come صراحة. As you can see here يعني the TNC it's in situ يعني no any invasion. T1A it's in the mucosa, invade the mucosa. T1B the submucosa, and any going on muscularis propria, subserosa, serosa, and adjacent structures. For the N, it's the number of lymph nodes that they're being involved, and we usually examine 15 or more than 15 nodes to make sure of our diagnosis. This tumor صراحة the doctor mentioned no, you don't need to know it, it's not important ثاني if you want to have a look on it. طيب, management of gastric cancer, it's based on the stage. So if tumor is resectable, we can go ahead with R0 resection, which is removing of the tumor, and lymph node dissection. We also have endoscopic resection for early gastric cancers that are confined to mucosa, and they are not beyond the mucosa. The best candidates are T1A, those who have no ulcerations and well differentiated. We either can have EMR or ESD. EMR, it's endoscopic mucosal resection, while the ESR, it's endoscopic submucosal dissection. تمام? Yeah, that's it for these two. Now, we can do distal or subtotal gastrectomy. This is when the tumor it's in the antrum or distal body. And by this procedure, we can preserve this proximal stomach and have a better quality of life. While the total gastrectomy, we do it when the tumor is proximal, when the tumor is diffuse type, when it requires wide margin, and we do reconstruction with the Roux-en-Y esophageal. We're going to talk about it, inshallah, in a bit. And finally, lymphadenectomy, which is D1 versus D2. D1 are this, as you mentioned before, the stations from 1 to 7 or 1 to 6 يعني. And D2 it's from 8 to 12. تمام. The current standard, the D2, it's standard for patients with T2 or lymph nodes involvements. تمام. And we try as much as we can to prevent to avoid splenectomy or pancreatectomy. طيب. We can do some minimally invasive surgeries like laparoscopic or robotic gastrectomy. They result in less pain, shorter hospital stay, and they have the same ecological standards. And the same operation is happening. Okay, instead, it's it's not that much invasive. If we have local regional disease or the disease have spread to somewhere else, we do surgery and preoperative chemotherapy. Now, if the disease was advanced or metastatic disease, خلاص, there's no cure for it, خلاص, we go ahead with the palliative care and we do treat the symptoms, and we check if the patient has any biomarkers that we can help in targeting them like HER2 or PDL1. And of course, we need a multidisciplinary team, including surgeons, oncologists, radiologists, and gastroenterologists. طيب. Now, we did gastrectomy. How should we go further? We do a reconstruction option. We have multiple reconstruction options, and each depend on the case that we do have, depend on the complications that may result from each one. طيب. First of all, we have Billroth 1, Billroth 2, and Roux-en-Y esophageal. So for Billroth 1, it's an end-to-end stomach. So from stomach to the duodenum, as you can see here, guys, it's from the stomach to the duodenum directly. It's the most physiological one, and food, as I mentioned, passes directly from the stomach to the duodenum. However, we may have a tension at anastomosis, and it's a good thing about it. It's that we have less bile reflux risk. تمام. Billroth 2, it's a stomach. We have the stomach. It's connected to the jejunum instead of the duodenum directly. However, the duodenum will be like a blind loop. Okay. Its advantage, it's simpler. It's easier to perform. However, we may have bile reflux into the stomach. Okay, and may cause loop syndrome. The last one, which is the Roux-en-Y esophageal, it's used for if we did the total gastrectomy. So we'll have two limbs, the alimentary limb and the biliary limb. The biliary limb will have the bile and the pancreatic enzymes, while the alimentary limb will carry the food from the esophagus directly. تمام. What's the one advantage for this? It's best at preventing bile reflux. One of the disadvantages is Reustasis syndrome, which we'll talk inshallah about in a bit. طيب. Pyloroplasty is a type also of palliative care where we do it to help facilitate the gastric emptying. When do we use it? When we have gastric outlet obstruction and late gastric cancer, after vagotomy, and as I mentioned, it's a palliative care. And what does it help us? Improving emptying, relieves vomiting and obstruction. No need to know how the procedure is actually done. Just know in Allah we have three types of pyloroplasty, which are palliative care. It helps us in relieving the gastric outlet obstruction. تمام. As you can see here, يعني we have the mycolex, which is a longitudinal incision across the pylorus. Okay, here we have a crescent incision, and here we have two longitudinal incision. However, it's not across the pylorus. Now, funny, last not least, we have after this something also. طيب, post gastrectomy complications. After the gastrectomy, we may have multiple complications. Why we may have these complications? Number one, loss of reservoir. Normally, stomach stores the food and releases it slowly. After resection, the fluid may enter the small bowel very fast, causing dumping syndrome. We also have loss of pylorus, which usually controls the emptying and prevent bile reflux. So without it, uncontrolled emptying and bile reflux, especially after Billroth 2. We have vagal degeneration, which controls the vagal nerve, which controls the gastric motility and satiety. If we have injury for it, we may have gastroparesis and early satiety. For the anatomical loops, we have creating loops can cause functional or mechanical problems. For example, in Billroth 2 or ROA NY, we do have loops, okay, and this may cause afferent loop syndrome or rheostasis. Also, we're going to mention it in a bit. طيب. First of all, we have dumping syndrome. We have early dumping and late dumping. طيب. What's the difference? First of all, early dumping, from its name, it happens within 15 to 30 minutes. However, the late dumping, it's from 1 to 3 hours. What's the mechanism? Whenever we eat food, as we mentioned, the food will pass fast to the small bowel. So the hyperosmolar chyme in the small bowel will cause fluid to move into the intestinal lumen from the intravascular environment. تمام. This will lead to decrease in the intravascular volume to drop, and the patient will present with cramping, diarrhea, and flushing. So, to summarize it, early dumping, it's a volume problem. تمام. And the volume will have the small bowel will be distended. How do you manage it? Small frequent meals and high protein fiber. Separate the liquids from solids and avoid simple sugars. تمام. طيب. Late dumping, it's due to the rapid glucose absorption, causing increased incretin and excess insulin, and obviously causing reactive hypoglycemia. The symptoms will have sweating, tremors, confusion, hunger, and also, to summarize it, late dumping is an insulin problem, while the early dumping was a volume or fluid problem. How do we treat it? As early dumping, small frequent meals, high protein fiber, separate liquids from solids, and we can use acarbose or octreotide. Acarbose for the late dumping, and octreotide if we had refractory episodes. طيب. Bile reflux gastritis. It's mainly, what do we mean by it? It's when the bile do refluxes to the gastric remnant and causes chemical gastritis. Why does it happen? It mainly happens after Billroth 2, and when we have no pylorus, so the bile will flow backward into the stomach. How do the patient present? Burning epigastric pain with bilious vomiting, and the vomiting doesn't relieve pain. تمام. It's very important لأنه you will differentiate this symptom between it and between the afferent loop syndrome. تمام. How do we treat it? Diet and of course medication first. Definitive treatment, convert from the build of 2 to ROA and Y. طيب. And as I mentioned, guys, when we have vomiting that does not relieve pain, it's bile reflux gastritis. While vomiting that relieve pain, it's afferent loop syndrome. Now, afferent loop syndrome that happens usually after birth of two. What do we mean by it? It's an obstruction of the afferent limb where we have the bile and the pancreatic secretions accumulate, and the pressure, of course, will build up. How do they present? Crampy epigastric pain. Okay, we have sudden bilious vomiting, and the patient do relief after the vomiting. This is a very important point. Here we have after vomiting, the patient is relieving. So why is it dangerous? Because it can become a closed loop obstruction causing ischemia, perforation, and this is an emergency case. How do we manage it? Resuscitation, stabilize the patient, of course, and imaging. And the definitive would be surgery. Okay, now let's continue with the Rowe stasis syndrome. It's a delayed emptying of the Rowe limb after the Rowe NY. How does that happen? We have disruption of the intestinal pacemaker activity. So the divided jejunum will lose the coordinated motility. So how will the patient present? We'll have post-meal fullness, nausea and vomiting, and abdominal pain. How do we treat that? First of all, we provide diet modification. We give prokinetics, and severe cases, we do surgical revision. Now, okay, so right now we're going to talk about the post-operative gastroparesis. Why does it happen? It's mainly due to the vagal nerve injury, and also we have motility changes after the distal gastrectomy. How does the patient present? We have early satiety, nausea, vomiting, and poor oral intake. How do you manage these patients? First of all, we correct the electrolytes. We do provide nutritional support, prokinetics like metoclopramide, and we look for watch and check the thiamine deficiency if the vomiting is prolonged. Now, finally, we have nutritional surveillance after gastrectomy. So patients need to check and always continuously till their whole life take these supplements: the B12, iron, calcium, vitamin D, and thiamine. B12 due to the loss of intrinsic factor maybe or acid in total gastrectomy. Iron due to the duodenal bypass and low acid. Calcium due to hypochlorhydria and the duodenal bypass. Vitamin D due to fat malabsorption. And finally, thiamine due to poor intake and vomiting. Alhamdulillah, we're done with our crash course. Inshallah, I hope that you benefit from it. If you have any question, please feel free to reach out. Here's the QR code if you can please rate us. So thank you very much. Have a good day.